Hello, everybody. Welcome to Grand Rounds on this sunny Monday afternoon. We are happy to have all of you joining us and happy for our Uptown colleague, Dr. Margrit Wiesendanger, to be joining us as well. As you may well know her, she's been on faculty since 2015 as an associate professor of medicine in the Division of Rheumatology, as the program director for the Rheumatology Fellowship on the Clinical Competency Committee for the Uptown Internal Medicine Residency, and recently as the course director for the med school's immunology course. Always delighted when I can share patients and stories and stuff with her, and so we are particularly pleased that she is joining us from Uptown today. Dr. Wiesendanger, take it away.
Great. Thank you so much, Dr. Weissman, for that kind introduction. It's my pleasure to join you today virtually, hopefully one day in person. But I'd like to talk to you about a fairly rare disease, but one that, has a lot of interesting immunological turns and twists, and something that we can all learn from. So these are the idiopathic inflammatory myopathies. We do have some new classification criteria, and hopefully that will translate into new insights. I don't have any financial support from any company or any product, but I do have uncompensated affiliations. So I just redid my rigor training, and it turns out should be also mentioned. So I'm a member of the Arthritis Advisory Committee for the U.S. Food and Drug Administration. I'm a board member for a Jewish organization downtown called JCP Downtown, which has an early childhood center and B'nai Mitzvah program. And I'm the new president of the New York State Rheumatology Society. It's a 2-year term, very exciting. Okay, so for today, these are the objectives. We're gonna discuss the key clinical, radiographic, and serologic features of these idiopathic myopathies. But I wanna highlight 3 of them that I think are very important to internal medicine and general doctors. The Antisynthetase syndrome, cancer-associated myopathy, and statin-induced necrotizing myopathy. And I want to also discuss some of the treatment strategies that we have for these different conditions. So it's a bunch of different conditions. I mean, what they have in common is that they're all systemic, and they attack striated muscle in some way. But beyond that, these are a very heterogeneous group of diseases, and they have different phenotypes, treatment approaches, and genotypes are different too. So I'll mention them all now in this slide, but I'm only going to focus on a few of them. So adult dermatomyositis has the typical rash of dermato versus polymyositis, which does not. Antisynthetase syndrome can be poly or dermato, but it has additional systemic features. And then you have immune-mediated necrotizing myopathies, the most important of which is the SRP associated, but there's also the statin-induced, which I want to discuss. There's a juvenile form of dermatomyositis, which behaves very differently from the adult form. Cancer-associated myositis, it's sort of like a paraneoplastic phenomenon. And then you have a very common one called inclusion body myositis. This is the most common in older men. Won't discuss it in detail today for lack of time, but it is in the categorization here. And then you have these overlap myositis syndromes, meaning the person has inflammatory myositis, but they also meet criteria for another major autoimmune disease. And the most commonly associated are lupus, rheumatoid arthritis, scleroderma, and Sjogren's syndrome. So the idiopathic inflammatory myopathies, not just muscle. There's more to it. There are definitely systemic diseases. The pulmonary system can be involved with interstitial lung disease, and I'm highlighting this because of the excess mortality that comes from this one. Many patients have Raynaud phenomenon, so that is a vascular situation. Most of them have muscle weakness. This is a myositis after all, but there's a subset of these disorders where the myositis is not clinically apparent, meaning they're not weak and they don't have elevated muscle enzymes. So these would be amyopathic myositis, so to speak. Many have arthritis. And since any skeletal muscle can be involved, you could have involvement of the pharynx, the upper third of the esophagus, so that would be dysphagia, or you could have involvement of the cardiac muscle. Thankfully rare, myocarditis, but it can occur with certain type of antibody, the SRP. And then the rash, which I touched on already, can affect different parts of the body. And is seen with a number of different antibody subtypes. So we have these criteria since 1975. Bowen and Peter described these very beautiful, simple, easy to remember, and yet very germane or telling you something important about this disease. So I'm mentioning them here, even though they have been superseded by a new set of criteria, because they were in force for decades. And so again, these are the ones that we've seen in medical school. You have the symmetric proximal muscle weakness, elevation of muscle enzymes, the most helpful being CPK, although aldolase can also be elevated without the CPK, and you can look at AST, ALT, and LDH as well. There's a characteristic electromyographic pattern, meaning it will show short duration, low amplitude, polyphasic motor units, which will be very easy to distinguish from neuropathic problems like amyotrophic lateral sclerosis and other disturbances of the EMG pattern that would not be pointing to a muscle cause. So neurologists are very adept at this. And then you have the characteristic muscle pathology on biopsy, which shows degeneration and regeneration of myofibers, a lot of lymphocytes infiltrating, and destruction, atrophy of the muscles around the fascicles. So those four things are each worth a point. If you have two of them, even without the rash, so two without, and it's possibly myositis. If you have three, it's probable. And if you have all four, then it's definite. And then the fifth criterion is the skin rash of dermatomyositis, which is the heliotrope, the Gottrins, holster, V-neck, shawl, etc., which has a characteristic biopsy pattern. So when they talk about muscle biopsies, this is what they mean. You have in panel A, showing you, it's a little bit of a low power, so it's a little hard to see, but you can see in cross-section all these little myofibers here. And some of them are actually quite okay. They're sort of pink and large. These are the normal ones. But many of them around the outside of the fascicle are, and especially here, they're smaller. So they're being destroyed. They're under attack. And then all those purple nuclei are inflammatory cells that are crowding around. So you see them around the fascicles, but you also see them around blood vessels. And as a result, you can get necrosis of these. This is another picture of that. These are up here in F. You have some normal, more or less normal muscle fibers, but then these are smaller and are being destroyed. So what's doing the damage? T cells, here seen in brown, so sort of infiltrating around, and B cells, and also again stained in brown. These are their nuclei stained in brown. Here they are. And as a result, you can so that's polymyositis, dermatomyositis. You'll see a lot of infiltrating lymphocytes. There is in the subset that is called necrotizing myopathy, you'll see destruction of muscle fibers. So here it's gone. It's just been replaced with scar tissue right next to a fairly normal looking muscle fiber, but not a ton of infiltration. So that's an interesting feature, that you don't see the same pathology on all of these myositis diseases. So there are definitely differences. Some have a lot of T cells and B cells and others don't. And also if the patient is biopsied after treatment with corticosteroids has been given, high dose especially, you may chase away these B cells and T cells and not see them on the biopsy. And then finally in H, I'm showing you that what happens after destruction, there's regeneration, and new regenerating fibers do express more MHC class 1 on the surface, and that's what's shown here in brown. This process can occur multiple times because muscle has a very good regenerating capacity, but eventually even this will be exhausted and the muscle will not regenerate and instead be replaced with scar, fibrosis, and fat. So the key is, can we figure it out before that's happened and stop the immune destruction? But now we have MRI. So this is a good alternative. If biopsy is not feasible, this can be a very helpful technology. So here I'm showing you, so you don't need contrast, but you need to tell the radiologist that you're going to want T2 stir or fat suppressed images. because you're interested in edema. You want to see muscle edema, which is water. So on the T1, fat is bright, water is dark. So it doesn't really show you what you need to know, because all the muscle looks kind of, we're looking at a cross section to the mid thigh. So here's the femur here, the bone, and then the muscle around it, and then the subcutaneous fat is bright. But here you can't tell what part of the muscle is inflamed. You can just tell that there's muscle there. Maybe it's a little swollen. On the fat saturated, so this would be the fat is nulled out. So now the fat is dark because you don't really want to look at that. Now you can see the muscle a little better, and you can tell which parts of the muscle have more edema or are inflamed, and they're the brightest parts. So there's some normal muscle sort of medially and posteriorly. It's a patchy process. There's more involvement in the anterior compartment, and that's pretty classic for inflammatory myositis, that the anterior compartments will be affected first. So you'll lose hip flexion before extension, for example. Okay, so MRI is great for figuring out if there's inflammation in the muscles. It can tell you which muscles are affected, how badly affected they are, whether fatty replacement has already occurred, for example. It can help you choose a biopsy site, right? Because you would want to choose a site that is actively inflamed, not totally already destroyed. And you can do multiple MRIs. It'd be hard to convince a patient to do multiple biopsies, but multiple MRIs, they could probably be convinced. And then you can see after treatment if there's been an improvement in the muscle edema. What about the skin? You can learn a lot about that. So here I'm showing the typical facial rash that one can see, and notice how, though there appears to be some sparing of the area around the mouth, the nasolabial fold is not spared. So unlike the case with lupus, where it's very photosensitive and thus the nasolabial fold will be spared by rash because it's relatively protected from the sun, that doesn't happen with dermatomyositis. On the other hand, if one is to biopsy a site, for example, here, showing Gottron papules on this patient's hands, you can see on the extensor surfaces of this patient happens to have a fairly severe case of dermatomyositis, where not just the area overlying the FCPs and PIPs is affected, but he also had a rash on his abdomen and a very extensive holster sign. It could just be part of the lateral thigh, but in this case, it extended all the way down to the anterior part of the thigh and beyond. He also had he had a shawl distribution as well. And this is the same patient, so different patient with this is an archival picture. The hand of this patient is the same one as here. And you can see that there is some thickening and erythema of the cuticles. So that is another, you can sort of see a little bit the scaly rash of Gottron that he also has. So in this case, the appearance of the rash was sufficient to render a diagnosis, and he did not require biopsy at this point. So again, one more caveat with skin biopsies: the dermatopathologist is unable to distinguish lupus from dermatomyositis based solely on the skin biopsy. They will have the same interface dermatitis and mucin deposition, and they will usually say very clearly, I can't tell, okay, I'm giving you the report. I cannot distinguish between these two conditions. You have to tell me more about where the rash is and the other features and what the serologies are. That's how you're going to know what you're dealing with. So speaking of serologies, this has been a very important advance in our understanding of inflammatory myositis. So I'm showing you here the workhorse antibody, IgG, the most abundant, the most important antibody that we have, just to remind you of the multifacets of this amazing molecule. So there's a tailpiece here that is released from the that actually can. This is the soluble type of IgG, so it has only the tailpiece, and then the FC region here interacts with receptors on the surface of phagocytes and natural killer cells, among other cells. It can activate and bind complement. And then you have the antigen binding site, which is at the tip. It has two identical antigen binding sites, which will recognize the target. So hopefully that target is COVID and not my own nucleus. So this is the antibody, and we have many antibodies that have been discovered over the past 20 years. Some are specific, meaning they're only seen in inflammatory myopathy, and others are associated with myositis, meaning they're shared. You can see them in myopathy and other autoimmune diseases, and that's the overlap that I was discussing earlier. So here are some of them. And what's important about them is they really do help to define a clinical subset in myositis, dermato or poly, and they are mutually exclusive. So if you send a biomarker panel on a patient and you get more than one positive, you have to decide which one is the real one. And usually there may be a borderline one and a very positive one. And so then it makes it easier. But this is sort of one of the caveats with these panels is that there may be some borderline values or some false positives. So just have to sort of think about where you want to put it in the context of everything else that's happening. So, and again, antibodies are helpful, but they're not the whole answer. So I want to highlight just a few of them. The antisynthetase antibodies are here in the top. They're, of course, affiliated with the antisynthetase syndromes, but the most common is JO1. And then you have PL7 and PL12. The others are very rare. TIF1 gamma and XP2 are important because they're associated with cancer linked dermato or polymyositis. So that's why we should pay attention to those two. And then HMG-CR, which is the HMG-CoA reductase, that one is important for statin-induced necrotizing myopathy. Here are some of the myositis-associated antibodies. They're pretty prevalent, but they're not specific for myositis. So if you have RHO or LA, well, that could be an overlap with Sjogren syndrome. PMSCL is the overlap with systemic sclerosis. COO is an overlap with lupus, and UNRNP is also an overlap with lupus. So the other, and then the two last words about serologies is that many patients with inflammatory myositis are ANA negative because their target antigen is not in the nucleus. It's in the cytoplasm. So if you did the ANA test with immunofluorescence, something could light up, but it may be the cytoplasm only, not the nucleus, at which point these tech will tell you it's ANA negative, which is technically correct. And finally, approximately 30% of patients with inflammatory myositis don't have any antibodies at all. So you'd have to rely on the remaining features to make the diagnosis. So there is a problem with the Bowen and Peter criteria because of these types of issues. There are mimics of myositis. So things that affect the muscle but are not an inflammatory myopathy. And they include muscular dystrophy, metabolic myopathy, endocrine myopathy, toxic myopathy. So which one of these could fulfill one or more Bowen and Peter criteria? Because some of these, for example, hypothyroidism, you can have a very high CPK. So it's a trick question, right? Any of them could fulfill the Bowen and Peter criteria. And that's the reason why a search for something better was undertaken. So, I mean, they did last for 40 years or more, like these rock and rollers lasted or have stood the test of time. You know, at the time when, in 1975, someone saved Elton John's life, and David Bowie was singing about young Americans, and Bruce Springsteen was a young American. And in case you were wondering, you know, these guys are still relevant. They participated in the Jubilee this weekend, the Platinum Jubilee of the Queen of England. But, you know, time goes on and music changes. This is 2017. And this is 2017 for the ACR EULAR classification criteria. So I tried to make this as clear as I could, but this is as good as it gets for the 2017. And there's no way to remember this. I could not remember these criteria, these points. It's like there's decimals in here. So there is a calculator, thank goodness. And so you could do that. It's sort of like doing the FRAC score. You can just log on and do it. So When no better explanation for the symptoms exists, then these new criteria can be used to diagnose or to classify, I should say. They're not diagnostic criteria, the classification criteria for adult and juvenile idiopathic myopathy. So I've highlighted some of the variables, and it depends. So they're a lot more detailed and specific than the original Bowen and Peter. And it depends if you have a muscle biopsy or not. You're going to be able to use the two types of point systems here. So let's say you don't have a muscle biopsy. The first variable is, did the first symptom occur in the ages of 18 to 40? Well, you get a point more or less for that. But if the first symptom started at age greater than 40 years, you get 2 points, 2.1. And you're basically adding up all the points. Is there symmetric weakness in the proximal arms? That's something. Or in the proximal legs also. Are the neck flexors relatively weaker than the extensors? If so, you get a point, almost 2 points for that. And if you're testing, since you're testing all the muscles in the legs, are the proximal muscles weaker than the distal? Then you have the rash. Heliotrope rash, 3.1 points. Gottron's papules, 2.1, and Gottron's sign, 3.3. So papules is raised and sign is flat. Dysphagia or esophageal dysmotility, you get 0.7. The only antibody that was able to survive validation is Jo1. But you get almost 4 points for that one. And then if there's an elevated CPK or LDH or AST or LT, you get 1.3 points. And then you have the biopsy. So if there is the very classic rim vacuole, then you get 3 points right off the bat. But you get almost 2 points for perivesicular atrophy, 1 point for infiltration of mononuclear cells, and 1.7 if it's, okay, so if it's perimesial, you get 1.2. If it's endomesial, it's 1.7. And then you add up all the points, and if your score is greater than 5.5 without a biopsy, or 6.7 with the biopsy, then it's probable inflammatory myopathy. If the score is 7.5 without a biopsy or greater than 8.7 with, then it's definite. Probability greater than 90%. So these are the new criteria. And if you compare the performance of the two from Bowen and Peter versus EULAR ACR, the sensitivity of Bowen and Peter was very high, but the specificity was relatively low. That was the main issue with this. So when you go to EULAR ACR, you lose a little bit in sensitivity, but you definitely increase the specificity. So I think this is a much better balance as far as that's concerned. Okay, so now I want to talk to you about just 3 of the interesting subtypes of these things. So first, the antisynthetase syndrome, which is myositis with interstitial lung disease, Raynaud phenomenon, mechanics hands, arthritis, and one of the 8 anti-tRNA synthetase antibodies. This is what it looks like in terms of the ILD. So this is actually a patient I saw, I still see. She's my patient. This is her CT scan from a couple of years ago when she was first diagnosed. And you can see this is so axial CT with the lung window, and you could see this NSIP pattern. So she has reticulations in the peripheral basal distribution, and there's relative sparing right here at the periphery, which is pretty classic. She had PFTs, which showed a restrictive pattern and a low diffusing capacity, a little bit out of proportion to the FVC. So that was indicating parenchymal lung disease. And she, on 6-minute walk test, you may see that the patients are desaturating. When you look at them clinically, you can learn a lot from just examining the hands. They may have Raynaud phenomenon, and patients sometimes take photographs so that you can see it in action. Mechanics hands is a sort of a rough, hyperkeratotic fissuring, superficial fissures of the skin on the lateral aspect of the fingers. This is a fairly mild case, but you can sort of see it here. The cuticular erythema and thickening I showed you on the other patient. This patient also has the chronic polyarthritis with some destruction of the ligaments so that it creates a swan neck deformity. Nail fold campyloroscopy can be incredibly useful. Just in the office to find these vascular anomalies. This is showing you a picture of where we're looking. We're looking at the cuticle. We're magnifying just this area right at the nail fold. And in the normal situation, the capillary loops are all nice and sort of look like little hairpins, all arranged in a nice, neat row. None of them, they're all the same. They're all lined up. But if there's a vascular problem, then they're going to start ramifying and becoming larger because some of them are being lost. So you may see these microhemorrhages and dilated loops. So that would be a very, so these pictures were taken with a microscope, which I have a microscope, but it's not this kind. I have one with polarized light, but you need a different kind of, the light has to come from above if you want to be able to do videos of people's nail folds. But there is a sort of a lower tech version of this, which is the dermatoscope that I carry in my pocket. And I also have an iPhone. And so these are the pictures I took with my iPhone. It's not as detailed, but it's something. You can definitely tell that there's a problem here with these nail fold capillaries. Here, some of them are missing and you have some dilated ones. Okay, so that's antisynthetase. I want to talk about statin-induced necrotizing autoimmune myopathy because even though it's really rare, statins are really prevalent. We all prescribe them, so we got to be able to tell what's going on here. So this is a condition which predominantly affects skeletal muscle. It's variable in severity, but it can be very severe with very high muscle enzymes, like rhabdo level of muscle enzymes. And you do see EMG findings of a myopathy with this condition. If a muscle biopsy is done, you'll see necrosis because it's a very aggressive myopathy with regeneration, but not a ton of lymphocyte infiltration. And this does not typically affect other organs in the way that antisynthetase does. This is purely a muscle problem. It's associated with current or past statin use, but it can also occur without statin use because, and I'll show you in a picture in a minute, muscle makes HMG-CR. It's on muscle tissue, not just in the liver. I want to contrast this with statin myalgias. Totally different story. So statin myalgias are very common. They get better with removing the statin. They don't require ongoing therapy. And there may or may not be a ton of CPK elevation. Statin-induced necrotizing myopathy requires ongoing immunosuppressive treatment. It doesn't get better. You have to remove the statin, of course, if it's there, but it's not enough. It's going to require IVIG and steroids. So one of the mechanisms proposed for this statin-induced necrotizing myopathy is that because the muscle cells have HMG-CR on the surface, that could be the target of the immune system. So the concept is that the myofiber is here, minding its own business, but it has HMG-CR on the surface, and then an antibody is formed against it, binds the surface of the myofiber, activates complement, and that results in destruction of the myofiber. And then more regeneration, more HMG-CR, etc. Why muscle cells would have HMG-CR? It is important in cholesterol synthesis, as we all know, and muscles need to make that for their membranes, and they may also need a certain amount of cholesterol for their lipid rafts and for contraction and excitation coupling. So it probably has to do the exact cholesterol that's on the surface of the muscle cell may be important in its function as a muscle cell. Okay. And now this beautiful algorithm I borrowed from Dr. Rohit Agarwal at the university, with permission, at the University of Pittsburgh Medical Center. And this is telling you, this is actually this was a talk he gave recently at Mount Sinai West. I love the slide so much, I asked him to give it to if I could borrow it. So essentially you have a situation where your patient is on a statin and they have some CKs. They may or may not be weak. And now you want to know what to do about it. So could this be something very severe or not? So the recommendation he came up with is to check the baseline CPK before even starting the statin, just so you know where this person lives, because some people have genetically higher levels of CK anyway, or if they work out a lot, they may have more muscle turnover normally, and it's not a problem. So you'd like to know, what is their baseline CPK? Then you start the statin. If they have no muscle symptoms, no problem, right? Just don't even have to monitor their CK. But if they do, then you have to recheck the CK. Okay, so they have muscle symptoms. If the CK is normal, their exam's normal, they're not weak, and they're tolerating their symptoms, I guess, then I guess you should continue the statin. It's a very important medicine. Just follow them closely. If, on the other hand, they're weak, you got to stop the statin. Or weak, or have an elevated CK more than 5 times the upper limit of normal, or more than 5 times the upper limit of their baseline, you got to stop the statin. If, on the other hand, it's a small elevation CK, let's say just twice the upper limit of normal, then you check for symptoms. And if the symptoms are intolerable, then you can sort of continue this pathway of stopping the statin and figuring it out. We do have a question in the chat. Oh, no, it's good. So then what if you stop the statin and the symptoms resolve? Well, you could re-challenge carefully, maybe a lower dose, maybe a different statin, maybe pravastatin and not simvastatin, or a non-statin. Figure out if there's a drug interaction, perhaps they're on something. But if symptoms persist more than 6 months or get worse, now we're talking, you got to worry. So now we're talking rheumatology, neurology, rule out other causes of weakness, ask for an EMG, maybe consider a biopsy, get the anti-HMG-CR antibody. And this is how you figure out if they have the dreaded statin-induced necrotizing myopathy. Okay, so now I'm going to, okay, now here's another scary one, cancer-associated myopathy. Is it a paraneoplastic disease, myositis? Well, in some cases, it seems to be, because all subgroups of adult onset myositis have at least a 2 and sometimes up to 7-fold increased risk of cancer, except for the antisynthetase syndrome and inclusion body myositis. So there's no increased risk. Also, the juvenile dermatomyositis, the pediatric dermatomyositis, does not have an increased risk of malignancy. So on the other hand, TIF1 gamma, NXP2 positivity does confer a higher risk. A more recent publication only saw TIF1 gamma as a risk, and NXP2 kind of was okay, but I would still worry about these two. And then the other one to worry about is the seronegative immune-mediated necrotizing myopathy. So the one that has no HMG-CR and no SRP. Though the seronegative necrotizing myopathy are at higher risk. The risk is highest within a year, either before or after the myositis diagnosis, but remains elevated up to 10 years after the diagnosis. And what the types of cancers that are seen are several: lung, breast, ovary, gastric, colorectal, pancreatic, and also lymphoma, typically Hodgkin's. So that means you'd have to screen for a lot of things, depending on the person. You know, at least a physical exam, but depending, mammography, pelvic ultrasound, PSA, CT imaging of the chest, abdomen, and pelvis, that's high yield. Abdominal ultrasound, endoscopy, colonoscopy in a sort of age-appropriate manner. So age-appropriate screening plus extra things. So if it's a very high-risk woman, some have suggested that just do a PET. You know, instead of like a million different procedures, just do one PET imaging for screening. So this is not a strong recommendation, but if you look at this, this is a lot of testing that we're asking these patients to do, and it has to be done at diagnosis, and again 1 year out, and then you still are worried about them for up to 10 years. So that's the cancer associated. The other part of this is the role of immune checkpoint inhibitors, which have really exploded in terms of the different types that we have available now. This is a picture of the PD-1, PD-L1 inhibitors and how they work, and the more and more indications that they're being applied to. So this is a big deal in cancer therapy, because you can release the T cells that have been silenced by the tumor itself, get them to attack the cancer by blocking PD-L1 and PD-1 or PD-1. So normally PD-1 and PD-L1 is important. Physiologically, it's important in the periphery to turn off completed immune responses, shall we say. So there always has to be a way, if you're fighting a virus or bacteria or fungus, to turn off the immune system once the threat has been eliminated. And also you need peripheral tolerance. You don't want random autoimmunity to occur in the periphery. So PD-1 and PD-L1 are important to turn off T cells that are no longer needed. But of course, the system has been co-opted by the tumor cell. It's figured out that it doesn't want the immune system to come kill it. So this is why cancer cells express PD-L1. They're able to turn off T cells. So again, this is a good approach for cancer therapy, but it has the potential to release latent autoimmunity or even start autoimmune disease in a patient who lacked this previously. So myositis is one of these. It's pretty frequent in terms of an immune related adverse effect of PD-1 inhibitors. This is an example. This is a case report of a patient just to illustrate the point. What was done here is they followed the CPK levels before and during pembrolizumab treatment. So before treatment, the CPK was sort of hovering between 400 and 1200, shall we say. But then here, these dotted lines is when the pembrolizumab was given, the first infusion, the 4th, and the 10th. And you can see that pretty soon after the first infusion, there's an abrupt increase in the CPK. And it happens again after the 4th. And then it sort of like calms down. They did treat the patient, but they continued the pembrolizumab, but they addressed the myositis. They also did PET CT imaging of the leg muscles. And here you can see that the muscles are lighting up on PET. So there is myositis here in the soleus, etc. So, okay. So this brings me to treatment of these conditions. So now that we know a little more about the pathophysiology, how do we manage? Well, steroids, of course, right? Steroids, they're the initial treatment in most patients with inflammatory myositis. The notable exception being IBM. Inclusion body myositis tends to have a variable response, sometimes no response to steroids. So it's sort of that one you have to think about. But in general, you would go with prednisone 1 mg per kg per day for moderate disease, and you may consider pulsing the patients with 500 to 1,000 milligrams IV of methylprednisolone first if they have severe myositis or extramuscular manifestations that you're worried about, like ILD. And then you would follow that up with the prednisone and then a taper. And so on the plus side, steroids are amazing. They're magical. They rapidly normalize muscle enzymes. They improve muscle strength. You have to also worry about people who have diaphragmatic muscle weakness or bulbar weakness, who have trouble, who are at risk of aspirating or stopping to breathe entirely. So steroids are important, but they're not effective as monotherapy. If you just try steroids alone, you're going to end up with flares, low remission rates. You will not get a full recovery and many, many complications that we all know about. So that's why there's something called the first-line immunosuppressive. They get started contemporaneously with the steroids. And if the disease is moderate, you can go with methotrexate or azathioprine. You could choose, they're both sort of one or the other, depending what's going on with the patient. If they have mainly skin disease, muscle disease, methotrexate's a great choice. But if they have an excessive alcohol use or liver disease or lung disease, you would not choose methotrexate. You would go with azathioprine. Also azathioprine, though it's pregnancy category D, it has a good track record in pregnancy, and methotrexate totally not. So the only thing with azathioprine, it's important to check TPMT enzyme activity before treatment, because those who have a low metabolic rate or who are not able to process, because this is a prodrug, so azathioprine has to be converted to the active moiety, first 6-mercaptopurine, and then it becomes 6-MMP and 6-TGN, and some patients don't have the correct alleles to do that efficiently. So It's important to first check the enzyme activity and then monitor metabolites during therapy to make sure they're mainly making the beneficial one and not the toxic one. Don't need that for methotrexate. But if they have moderate to severe myositis and or more disease like interstitial lung disease, you're going to go with the second line. The second line may become the first line. So mycophenolate mofetil or mycophenolic acid, which are the inosine monophosphate dehydrogenase inhibitors, or cyclosporin or tacrolimus, the calcineurin inhibitors, one of these two may become the first line immunosuppressive. Again, if there's severe myositis or refractory myositis, ILD, and then you have the pregnancy categories. Cyclosporin is safer than mycophenolate. Well, mycophenolate is not safe, period. Can't do it. But you still have to check the troughs on these drugs to make sure you're reaching your the right levels. What if they don't work? Well, then there's cyclophosphamide, which is sort of the cruise missile that we use in rheumatology, or rituximab. So different, cyclophosphamide has been around for longer, but it has a higher risk of toxicity than rituximab. So I would say if it's a choice between these two, unless there's a real reason why rituximab cannot be used because of patient preference or something like that, there is a growing body of evidence that rituximab would be effective for interstitial lung disease and vasculitis. So if those two things are happening, I would say rituximab is superseding cyclophosphamide. Patients who have high levels of autoantibodies tend to benefit most from rituximab, which makes sense. It's a B-cell depleter, so why not? IVIG, though, is the most exciting thing that's happened in inflammatory myositis. It is the first and only drug that has been approved by the FDA for the treatment of myositis. And that just happened last year. So it works for refractory dermatomyositis with muscle weakness and rash. It's very safe in terms of pregnancy, infections, malignancy. I mean, after all, it's used for the treatment of people who have immunodeficiencies in the B-cell compartment. The only caveat, it's expensive, but there are newer ways to give it that are maybe insurances will be more happy with, which is subcutaneously at home as opposed to IV in the treatment center. How does it work? Well, it's a very interesting mechanism. So here I'm showing you how antibodies interact with phagocytes and natural killer cells in a normal immune response. So this would be the physiologic way that antibodies are supposed to work. B cells make antibodies in response to a microbe, and then the antibody by itself can neutralize the microbe by binding a key receptor on the surface, or it can instruct a phagocyte via Fc receptors, hey, this is a bug you need to destroy. It can also activate natural killer cells that could destroy an infected cell, and it can activate complement. So what IVIG does, what you're doing with IVIG is you're flooding the system with a ton, I mean, super therapeutic or super physiologic, it's very therapeutic, super physiologic amounts of immunoglobulin, mostly IgG, and it's sort of going everywhere and binding all the Fc receptors. But because the donors for the IVIG typically don't have an autoimmune disease, because they're pretty rare, like less than 1%, fewer than 1% of people have autoimmune conditions. So what you're getting in your IVIG is IgG against measles, shingles, flu, even COVID. That's what you're getting. And so they're not going, these extra antibodies are not going to bind the autoimmune targets in skin, muscle, and lung that the patient's having to contend with. So they will not activate the phagocytes. In addition, one of the main ways that B cells get turned off after an immune response has been completed is by the extra Ig that's around. So that's not binding anything. That's not binding a target. So it gives a negative feedback to B cells and just turns them off. And they contract, they die. So if you flood the system with all that extra Ig, it's going to turn off ongoing immune responses, which is what is probably how it's working in the sense of autoimmune disease. Another thing that's really cool is that in case you've wondered, why do antibodies have a half-life of up to more than 3 weeks? that's a really long time to survive in the blood, because the plasma of the blood is full of proteinases, and they just go around and destroy things all the time. One way to hide from these is to have a carrier protein like albumin. So if you can hitch a ride, if you're a small protein, you can hitch a ride on albumin, that big protein is going to protect you from these proteinases. But what if you're an antibody? You can't hitch a ride on anything. That's not how antibodies, they don't interact with albumin or other big proteins. Instead, they have that Fc portion, and it binds FcRn, a receptor on the surface of the endothelial cells that line the blood vessels. And so what happens is immunoglobulin G can get endocytosed by so here we're looking at a endothelial cell in a blood vessel. So over here is the lumen of the blood vessel, and this is one of the endothelial cells that lines it. So it's constantly picking up plasma proteins and things just as a matter of course. So the IgG gets endocytosed, and then when it ends up in the endosome, it's going to bind. So it was attached to an Fc receptor here. So it gets taken up to the endosome, and then it's acid, the pH, so it gets it stays on the IgFcRn because it's very sticky, and then it gets recycled over here to the recycling endosome, as opposed to the remaining proteins which go to the lysosome. So it gets released then at the surface by the recycling endosome, and it can now float along, as it were, to the next endothelial cell, and it will hide in that one. So it kind of hopscotches down on the side of the blood vessel, and it hides from the proteases. So that's how normal IgG survives for so long in the bloodstream. But what if you flood the system with all these extra Igs? They're going to kick off, they're going to outcompete the autoimmune ones. And so the autoimmunes will be left out here in the lumen, and they're going to be chewed up. So this is a good way to get rid of the autoantibodies. All right, so that's IVIG. I know I spent a little extra time on it, but I thought it deserved it. So now IVIG could be considered first line even with steroids for a patient with myositis. There are other biologics and biologic DMARDs like tofacitinib that have been looked at for the treatment of inflammatory myositis. Unfortunately, the results have been mixed and sometimes negative, so they're not being recommended. So abatacept, tocilizumab, tofacitinib, and etanercept have all been studied, but it doesn't work. So that's it for treatment. So in summary, the idiopathic inflammatory myopathies are a heterogeneous group of systemic diseases. They're not just affecting the skeletal muscle. We have the benefit of many discoveries in the last few decades of specific antibodies and new classification criteria, which will help us identify these patients with more specificity and hopefully earlier in the course so that we can initiate the correct treatments. We do need a multidisciplinary team because of all the different organs that can be affected. We need pulmonary, we need cardiology and dermatology and neurology. And we have to worry about cancer in a bunch of these different risks depending on the antibody and the type, but still it's out there. Early institution of corticosteroids can be life-saving. It's the first, but you do need a first-line immunosuppressive for induction as well as steroid sparing. And finally, I said it already, but IVIG is the first FDA-approved treatment for inflammatory myositis. So I want to thank you for your attention. Just want to mention that when I was a medical student, I did 2 clerkships at BI, OBGYN, and my sub-I. And I want to thank Dr. Dewitt Pyburn for teaching me that asymmetry is not always pathology, and that sometimes the patient is lying cattywampus on the scanner. So it's okay, the brain's okay, just have to make sure. And I want to highlight Dr. Ira Khanna, who was a resident at MSBI and then became my fellow here at Mount Sinai East, and we're hiring her. So she's going to be faculty at Mount Sinai West. So Dr. Khanna will be doing the full circle of Mount Sinai All that's left after this is Queens and Brooklyn, I think, and South Nassau. But we have no intention of letting her go anywhere. So again, thank you so much for your attention. I'm happy to take any questions.
Excellent. Thank you so much for that engaging talk and for the update on Dr. Khanna, who I was in touch with not that long ago. We'll open up the floor to questions if people want to either put them in the chat or unmute themselves.
I have a question, actually, about the steroids-induced like myopathy. Like when following up, patients with dermatomyositis who is on steroids, and then like if like the patient develops, myopathy or like increased CBK or like symptoms, muscle-related symptoms, how would you, differentiate like between steroid-induced myopathy and the like worsening of like primary dermatomyositis?
Yeah, that's a very good question, because it's also going to be proximal. Even if it's steroid myopathy, it will be a proximal myopathy because those are the biggest muscles. So that's where you're going to really notice it. So typically with pure steroid myopathy, the CPK will not be elevated. It'll just be weakness without a CPK elevation. But there is a way of figuring it out. And you could do a biopsy, but because it's typically only type 2 fibers I think that's not necessary to diagnose it that way. I mean, I would definitely do a blood test, but then MRI will tell you what you need to know. You can do an MRI of the weak muscle that you're worried about. And with steroid myopathy, there will not be edema in the muscle. It's not going to light up. But if you have a flare or recurrence of your dermatomyositis or polymyositis, it will. And, you can also tell on MRI if you've had fatty replacement or scar. Because if that's happened, the CPK will also not be high. So I would recommend MRI. You can also do EMG, because EMG can distinguish between active myositis, because there'll be fibrillation potentials. When they insert the needle, it's going to go crazy. That's active myositis. But if they just insert the needle, nothing happens, and then they sort of see kind of deranged muscle, that could be chronic or, damaged muscle, shall we say. You can tell on the EMG as well.
Thank you so much. Any other questions?
I answered all the questions. Didn't even get to talk about all the myopathy.
If like anyone else doesn't have a question, I have another one. So if that's okay. We recently invited Dr. Maria Padilla from the division of Margrit.
Yeah.
She talked about interstitial lung disease updates, and then how do you like work with Dr. or like a division of Margrit, like for patients presenting with interstitial lung disease, especially the diagnosis is like not like made.
Yes. Right. So I didn't mention this, but you're touching on an important point, which is sometimes the muscle involvement is delayed compared to other systemic features, or not at all present. We had some MDA5 patients who had amyopathic myositis and very severe lung disease. So there's two ways. So one is in about 6 minutes, we have the working group for interstitial lung disease is starting on Zoom, and I'm in it. It's mostly pulmonary critical care, but it also has Dr. Beasley, who's the pulmonary pathology person. She usually has slides with the biopsy results, plus radiology. So what we do is we talk about all these cases together, because we try to get as close as we can to the correct diagnosis. And what they have done in pulmonary critical care is anybody who has NSIP on the CAT scan gets a full panel of autoimmune serologies. And that they really don't want to miss a single case. Even if the person has no symptoms that are suggestive of it, they'll get the blood test. And if either the blood test is positive or they do have a concern, they'll send me the patient. So we kind of work up the patient in parallel. I think that's the best way to do it.
All right.
All right.
I think you answered everybody's questions. So that's perfect. Thanks so much for joining us. We do hope to see you down here in person before too long.
That sounds great. Thank you so much.
All right. Thanks, everybody.
See
Thank you.
all.
Thank you,
Bye.
Dr. Wiesendanger. Thank you. All right, we're gonna close the meeting. All right, have a great afternoon.
Thanks, Ayato.
Yeah, thank you, Minir. Awesome.